So good morning, everyone. So today we're going to be talking about glomerular disease, which I know is everyone's favorite topic. Oops. My first question to you is, what is the function of the glomerulus? What does it do, essentially?
So it's numerous functions. It's going to balance osmolality of the blood supply as well as the urine, and so it reads the. So you have the osmolality as you go closer to the further from the cortex and closer to the medulla gets more or less concentrated depending on how the pipeline is. So the role of it is probably to take osmoles out of the blood supply so you can get it out. Otherwise, also it's screening for macro and macromolecules in the proximal tubule, and then do a little bit of electrolytes as you go further down the pipeline: calcium, sodium, potassium.
So if you were going to use a one word to describe its function, what would it be?
Filter.
It's a filter. Good. It's a filter. And I think when you talk about the physiology of the nephron, it's important to think about it in these terms. Really try to simplify things. The glomerulus really is a filter, right? Its major role is to create an ultrafiltrate, right? To basically make sure that larger proteins, cellular elements, red blood cells, white blood cells, are not entering into the tubule. Right? The remainder of the tubules and ducts after the fact, you can really think of as an assembly line, right? Each portion, the proximal convoluted tubule, the loop of Henle, distal convoluted tubule, your collecting ducts. From that point forward, each have a specialized job to do to work on that ultrafiltrate, right? Reabsorb certain things, secrete other things, maintain fluid homeostasis, electrolyte homeostasis, acid-base status, right? And so each portion of that duct, of those tubes, will serve a very important role. Now, with that being said, what are the two major types of glomerular disease we encounter on a regular basis?
Glomerulonephritis.
Good. So glomerulonephritis, otherwise known as nephritic syndrome.
And nephritis.
Nephrotic syndrome. So what are the similarities? What are some of the differences from a pathological perspective?
So they're both within the tubular system. The filter, if you will, is too large.
Okay, so there's an issue with the filter,
Right.
right? For one way to think about it. And you can really think of nephrotic and nephritic syndrome being on a spectrum, right? With nephritic being on one end, nephrotic being on the opposite. And which one is associated with probably more damage? Nephritic comes on quite rapidly. You get pretty significant damage to the glomerulus, and as a result, yes, you get proteinuria, but you start to see cellular elements appearing in the tubules and subsequently in the urine. So there's going to be a lot more hematuria with nephritic. Whereas nephrotic, less true damage and a lot more what we call architectural distortion. Right? So not as much necrosis, not as much damage, right? But you may see changes in the proteins, so you can no longer deflect the negatively charged albumin from the glomerular basement membrane. May become a little bit of more of a sieve, right? And it'll allow protein, but not the larger cellular elements into the tubules. Now, there's going to be considerable overlap, as we'll see. And certain diseases like membranoproliferative glomerulonephritis, IgA nephropathy, can at times do either or. So, first question of the day. All the following are a common feature of nephritic syndrome except A, hematuria with red blood cell casts, B, proteinuria, 3.5 grams or more over 24 hours, C, hypertension, D, azotemia, or E, edema. And the number is 110-774-8. 10 more seconds. Okay, so what do you guys think?
Protein urine in 3.5 grams.
Okay. What do we call that if you're spilling that much protein in your urine? Nephrotic proteinuria. So if we're going to look at if we're going to take a look at what constitutes nephritic syndrome, these are really the 5 major clinical characteristics. Hematuria, with the associated red blood cell casts and dysmorphic RBCs. And what do we mean by dysmorphic RBCs?
They're like squeezed out.
Mm-hmm.
And you have like a green or
Okay.
not really shaped like red blood cells.
Good. So we have misshapen red blood cells, and we have RBC casts, right? Basically red blood cells that are clumped together, glued together. There's proteinuria. Now, most of the time you're going to see less than 3.5 grams over 24 hours. And I underline usually because there's a one-way overlap between nephritic and nephrotic. Nephritic syndrome can at times have nephrotic range proteinuria. Okay? But nephrotic syndrome should never have significant hematuria. Does everybody understand that?
Yes.
In addition, you're going to see azotemia, edema, and hypertension. So let's talk about why this happens clinically. Anybody want to take this? Sam, go ahead. So why do we get hematuria, red blood cell cast, dysmorphic RBCs?
So essentially, so coming back to this whole filter concept, so now we're
Mhm.
trying to, we kind of spoke about the larger proteins, you have larger molecules essentially trying to squeeze through that are actually, that should not normally
Mhm.
be getting through this filter.
Mm-hmm.
It's squeezing through and it becomes dysmorphic, as opposed to something that would be distal to the nephron itself.
Mm-hmm.
The glomerulonephritis, where you would not see anything dysmorphic, you'd actually see just normal looking RBC.
Good. And that helps you differentiate between 2 types of hematuria. You have glomerular hematuria and non-glomerular hematuria. Right? Bleeding that occurs distal to the glomerulus will not be associated with dysmorphic RBCs and red blood cell casts. Right? So if you have a neoplasm, you have a renal calculus, right? You have an infection that will cause bleeding, but you won't see those findings. So very important to always spin the urine, look at the microscopy, and try to make that differentiation from the get-go. So you're right. So if we take here, we said the glomerulus is a big filter. So here's your tuft of capillaries, right? Here's Bowman's space. And what ends up happening is you're getting significant inflammation and damage, right? As a result, your red blood cells can now squeeze through. And when they're squeezing through that fence, they can be damaged. They become misshapen, and they call those acanthocytes. Now, why do we see the red blood cell casts forming?
So I think it's stuck, there's enough in the tubule.
Good.
Areas, there's something called TAM phosphol protein, which is just a basic protein in the environment. So
Mhm.
that can help congeal it further if it's already backed up, and keep the shape. That's captured pressures.
Good. So you start to see.
Keeps its shape when it goes into the bladder and urine and catches.
Okay. So it acts as a glue, right? It sticks them all together, and you get a whole clump of red blood cells that really take on the shape of the tubule. And you'll start to seal. You can see that under the microscope. Good. Why do we see proteinuria?
You have damage to the basement membrane or,
Mhm.
so there gets to be like albumin, well, other proteins that are smaller than albumin can leak through,
Mhm.
just like the red blood cells.
Good. So that filter is now acting as a sieve, right? So protein is escaping as well. Now, why do you develop azotemia? Like renal insufficiency?
You clogged up?
Yeah. Right? So all this inflammation is basically clogging up the filter. And so what happens to your filtration rate, glomerular filtration rate?
Decreases.
Decreases, along with your creatinine clearance and your ability really to remove nitrogenous waste, right? So it can also affect, again, fluid, acid base, and electrolyte homeostasis. Now, why do we get hypertension and edema?
Increase in renin angiotensin
You're collecting.
combined with the decrease on cardiac pressure.
Okay.
Causes an ongoing arrhythmia that's then going to lead to increased fluid retention, which is then going to third space and cause pain.
Okay. So if you have nephrotic range proteinuria and you have reduced albumin, that's going to lower your oncotic pressure and allow the extravasation of fluid, which may lead to edema. But probably even more importantly, right, as we said, your GFR will fall, and this nephron is going to pick up, right? Basically, you have a reduced effective circulating volume, right? So what's going to be released from the kidney here?
So renin,
Good.
and then followed by gradually by aldosterone.
Good. So renin gets released.
And then aldosterone.
And you set off that whole cascade, right, including now the formation, so your renin, angiotensin, aldosterone system. And the angiotensin, particularly angiotensin 2, does what? It tenses the angios, as the name implies. So it's going to cause vasoconstriction. You're going to increase your systemic vascular resistance. Blood pressure will go up. And then, as you said, you're also going to activate aldosterone, which will work more distally, and have what effect on the nephron? What is it going to stimulate? Good. So sodium and water reabsorption. That's further going to increase blood pressure, but now also lead to worsening edema. So you can see right away that, you know, the clinical features really fall nice in line with the pathophysiology. And here, again, this is what Sam was talking about, trying to differentiate glomerular hematuria from non-glomerular hematuria. Glomerular hematuria, you will see RBC casts, dysmorphic RBCs, and significant proteinuria. Features you will not see in non-glomerular hematuria. And if you look here in picture A, these are your normal appearing red blood cells, nice and circular, whereas here is what Shivani was talking about in terms of acanthocytes, right? They're all misshapen. They must look like they have little knobs protruding from them. Again, that's because they're squeezing through that damaged fence. And then down here is your typical appearance of an red blood cell cast, where each of these individual red cells are stuck together, are glued together, and they will assume that shape of the tubule. Yeah. Oops. Second question.
So we're talking about the, have you ever history of controlling infections while in the hospital for elevated serum creatinine and abnormal urinalysis 5 days after admission for CMV, retinitis, and latent syphilis? He has previously refused treatment with highly active antiretroviral therapy. The medications are camzycovir, trimethoprim, sulfadoxazole, metoprolol, intramuscular penicillin and low molecular heparin. On physical exam, temperature is normal, blood pressure is 150/88, pulse rate is 88, and respiration rate is 16. BMI is 22. Fundoscopic exam reveals yellow-white fluffy retinal lesions adjacent to the retinal vessels. Cardiopulmonary exam is normal. Cutaneous and neurologic exams are normal. There is trace bilateral lower extremity edema. Hemoglobin is 8.6. Leukocytes, 4,800. Platelet count, 168,000. CD4, 60. HIV RNA, viral load, 147. VDRL positive, antibodies test C virus positive. C371, C4 7. Serum creatinine 1.9. Urinalysis 3 plus protein, 1 plus blood, 15 histologic lymphocytes, 2 to 5 lymphocytes, occasional lymphocyte casts. Urine protein to creatinine ratio 2.3. On kidney ultrasound, the right kidney is 11.6 and the left kidney is 11.8. The aperture of the neoparenchyma is
And just for reference, the C3 is normal, the C4 is low. So is this A, IgA nephropathy, B, post-infectious glomerulonephritis, C, immune complex mediated glomerulonephritis, D, granulomatosis with polyangiitis, the vasculitis formerly known as Wegener syndrome, or E, Goodpasture syndrome. And the number is 110-7751. And I'll do the Charlton scroll. Ten more seconds. Okay, so Shivani, what do you think?
So this patient has HIV and recently blood counts. He has AIDS,
Mhm.
and he had an AIDS-like illness, Glomerulonephritis.
Mm-hmm.
On his exam, he's shown signs of like a glomerular issue. He has lower extremity edema. I think he said, oh yeah, he was like hypertensive.
Mm-hmm.
So, and then the urinalysis showed 3 plus proteinuria, which I think is not yet in thyroid range.
Mm-hmm.
And also dysmorphic RBCs. So, idiopathic cast, so that is more likely to be nephritic syndrome.
Mm-hmm.
So out of the answer choices, IgA nephropathy, he doesn't really fit the demographic for this. Most people with like concurrent like pharyngitis,
Mm-hmm.
and also it's also like not as common in people who are immunocompromised.
Mm-hmm.
Post-infectious glomerulonephritis.
Although I will say you can see IgA nephropathy in HIV. Everyone, when we talk about HIV-associated nephropathy, always jumps to the collapsing variants of FSGS. But you can see IgA nephropathy associated with it. Why else is this not IgA? Something to do with some of the lab values. Good. Complement in this disease should be normal. And here we're seeing a reduced C4. Good.
Post-infectious glomerulonephritis could also be an answer choice, but he's not, I mean, the complement levels are low in this as well,
Mm-hmm.
but it didn't say that he had any like recent bacterial illnesses.
Good.
Like 2 weeks after infection.
Good. So both of these will cause a hypocomplement. This one will cause a hypocomplementemic glomerulonephritis. This will not. Right. That's one way of differentiating, which is usually lower in post-infectious, C4 or C3. C3 tends to be lower than C4. In this patient, the C4 is lower. Another way to try to differentiate that is the timing related to the illness. Post-infectious, as you would expect maybe with post-streptococcal, is usually several weeks after the fact. Whereas IgA nephropathy, the glomerulonephritis begins shortly after the infection develops. So the time course can be helpful here. Good. We'll come back to C. What about D?
Granulomatosis with polyangiitis. This could be possible, but in this we also would see a decreased complement. And he doesn't have other like manifestations like pulmonary or like ENT manifestations of it.
So no upper airway, no lower airway manifestations. Does have the glomerulonephritis. Now, complement here should be, is that low or normal?
Normal.
Should be normal, but what antibody will be seen?
Or C exon.
Good, so the C-ANCA with specificity to antiproteinase 3. Good, so we're not seeing that. And then finally, good pastures?
Good pasture syndrome, complement level is also normal for this. And it's a pulmonary renal syndrome with anti-glomerulonephritis membrane antibodies.
Good.
So, you know, like, could be demographic.
Mhm.
So immune complex mediated glomerulonephritis, can be caused by several different etiologies.
Mhm.
Honestly, I picked it as like, causes of inflammation.
Mhm.
So,
What do you think is the cause of this in this patient? What diagnosis would you describe with hypocomplentemic glomerulonephritis with a low C4, given his comorbidities? Yeah. So the one you have to be really concerned about is cryoglobulinemia due to his underlying hepatitis C. But I think this case is very instructive in terms of how we want to approach glomerulonephritis. This patient certainly had nephritic syndrome, as you said. You know, we saw the hematuria with this cast, dysmorphic RBCs. We saw non-nephrotic range proteinuria. We saw the edema, the hypertension, the azotemia. So that's our starting point. Really, the next thing you want to really try to do after you've made this diagnosis is try to put someone in one of 4 categories. Now, we're not going to talk about hereditary today. That's going to be seen more in pediatrics. It seems like it's more acquired. But these are really the 3 big boxes, right? Anti-GBM disease, immune complex mediated disease, or ANCA-associated disease. These are really the 3 major presentations, okay? Or pathologies, we could say, that could be associated with nephritic syndrome. Anti-GBM, as you said, this is where you have antibodies against type 4 collagen, and that's going to be found in the lung and the kidney, and that'll lead to that renal pulmonary syndrome. So oftentimes diffuse alveolar hemorrhage, along with glomerulonephritis, you'll see positive serum anti-GBM antibodies, and if you were to biopsy, what would you see? Good. So linear staining along the basement membrane. So that does not really fit the situation. On the flip side, you have ANCA-associated. And ANCA-associated is usually associated with vasculitides. And although if you have no other features of vasculitis, you could say that this is ANCA-associated glomerulonephritis. The major vasculitides we'll see here, granulomatosis with polyangiitis, Wagner's, but again, usually have upper airway, lower airway, and glomerulonephritis. Microscopic polyangiitis, which really looks just like granulomatosis with polyangiitis, but what are some of the distinguishing features here?
And the specificity of
Good. So both will have ANCA. GPA tends to have antiproteinase 3, which is C-ANCA. Microscopic polyangiitis is myeloperoxidase, which is P-ANCA. Good.
And microscopic polyangiitis, it affects the kidneys more so than upper airways.
Good. So microscopic polyangiitis, you can get lower airway disease, so in the lungs, right? You can get glomerulonephritis. You tend not to get significant upper airway disease. Very good. Scherg-Strauss, how does this present? So asthma, high eosinophil count, and then as the disease progresses, those eosinophils can accumulate in tissues causing organ dysfunction, and eventually you can get a small vessel vasculitis. We're not seeing anything along those lines. So then we move into the middle box, which is immune complex. And this can be further differentiated by normal complement levels or low complement levels, what we call hypocomplementemia. Normal complement, as we said, is usually IgA nephropathy, which may be associated with another small vessel vasculitis, particularly in kids, known as Henoch-Schönlein purpura. Right? And what are the clinical manifestations here? Good. So rash, which is the palpable purpura, abdominal pain due to the small vessel vasculitis. At times that may cause GI bleeding. arthralgias, right? And then finally, IgA nephropathy. So it doesn't really fit this picture. Low complement is what this patient has, right? So you want to further break down into post-infectious, right? SLE, endocarditis, hypoglobulinemia, or membranoproliferative glomerulonephritis. And each of these may be associated with different complement levels being low. Post-infectious, as we said, is usually low C3. SLE, C4, good. Cryoglobulinemia, C4. And mixed essential cryoglobulinemia is associated with hep C. So this is probably the most likely diagnosis in this patient. So just to recap, I think things that we really want to walk away from knowing first and foremost what the glomerulus should be doing, understand the spectrum between nephrotic and nephritic, knowing that there can be considerable overlap at times, particularly with nephritic syndrome having nephrotic range proteinuria. You really want to know the clinical manifestations of nephritic. How do you diagnose it? And then last but not least, I think once you have that, you want to be able to kind of take this advanced organizer, this algorithm, and walk your way through it. This can be particularly helpful clinically before you go ahead and biopsy the kidney. Because just by checking anti-GBM antibodies, complement levels, including CH50, C4, C3, and NK antibodies, you often have a good idea of what your differential diagnosis is going to be, even before obtaining tissue. And last but not least, you definitely want to keep in mind the pathophysiology. Because if you understand this, there's less memorization. Right? So know what's happening as this filter is damaged. Any questions with that? So moving forward, we'll talk about the other glomerular disease, nephrotic syndrome, right, at a later date. Thanks, everyone.